briefly about bacterial pathways into the pulp and then quickly move on to clinical diagnostic methods. Why it is important to discuss bacterial pathways into the pulp is because the pulp is the soft tissue encased into the hard covering of the dentine enamel, the cementum and the gingiva and alveolar bone. So there should be some pathway through which the stimulus has entered. Only then there will be pain and infection of the pulp. So that is the reason why bacterial pathway is important. So the different pathways through which the pulp can be infected or cause a trauma are through the dentinal tubules from the caries invasion. So if there is a dental caries that has happened and it has become a deep caries, that can reach into the pulp. Second is traumatic exposure of the pulp, quite self-explanatory. The coronal leakage after restoration, internal or external resorption from periodontal tissue through exposed dentinal tubules through the accessory or lateral canals or the apical end. One of the important reason why later we will discuss, whenever apicectomy is conducted, we always say to remove at least 3 mm of the portion because maximum amount of ramification is seen in that portion of the root. And last is the lymphatic or the hematogenous root, which is also called as the anacrosis. There are two types of endodontic infection. One is the intraradicular, that is infection within the canal, and other is the extraradicular, where it is about the periradicular tissues. So in intraradicular infection, we have three types. First is the primary, which is caused by the colonizer bacteria. The secondary, which is present during or between the appointments. And the third one is the persistent. Those bacteria are the ones which are persistently present even after a thorough antimicrobial procedure has been conducted. So in extraradicular, the example of one such scenario is the acute alveolar abscess. Clinical diagnostic methods. Listen to your patient. The patient will give you the diagnosis. This is a famous quotation by Sir William Oscar. In my opinion, it is easier to treat a patient than to diagnose the positive tooth for the radiating pain. Clinically, it is very common that a patient will be reporting pain in the mandibular teeth when after the entire diagnosis is over, we will find that the actual causative tooth was in the upper arch. So, today we will entirely discuss all the steps and procedures and logical order of diagnosis that is required for a endodontic. Diagnosis consists of the examination, taking into consideration the signs and symptoms and the correct determination. The procedure follows should be consistent logical order comprising of the medical and dental history, the radiographic examination, intra and extraoral clinical examination, written history in a form of questionnaire and a duly signed consent. In the process of taking down the history, we should note down the chief complaint of the patient, the past medical history, past dental history, and the present medical and dental status. Now we'll be discussing about symptoms. Symptoms can be defined as phenomena which is departure from the normal and as an indication of illness. Symptoms can be subjective or objective. Subjective symptom is pain. Now we have to elaborate pain in order to understand it better. For pain, we have to elicit all the questions such as the nature of pain, the location, the duration, the elevating factor, the relevating factor. In pain, when the patient gives us a history that there is a sharp piercing or lancinating kind of a pain, we have to understand that that is from the A delta fibers, and such kind of pain can be well elicited by cold test. Whereas if the patient gives a history of dull, boring, gnawing, and longer duration pain, those are from the C fibers, and such pains can be elicited better using the heat. A tooth which has a pain but disappears on removal of that irritation is an example of a reversible pulpitis, and mostly in such cases there is no requirement for an endodontic therapy. But cases where the pain elevates due to heat, it is nocturnal in nature, that the patient is giving a history that at night time when the patient is putting the head down on the pillow, due to the fluctuations in the dentinal tubules of the fluid, such things, also the pain which occurs more during mastication, these are categorized under irreversible pulpitis case, and this scenario definitely needs an endodontic therapy. Now we will be discussing the objective symptoms, wherein we will perform the test and as clinicians, and we will find out that which is the correct tooth that is causing all the problem. Although it may not be necessary to perform all the tests at one time, a combination of tests to corroborate is desirable to ensure a correct diagnosis. One should not rely on only a single test. Visual and tactile inspection. This is the simplest clinical examination. Here, basically, three C's are checked: the color, contour, and the consistency. Coming to the color, contour, and consistency of soft tissue, deviation from the pink color of the gingiva suggests a pathology. Change in contour, that is in case of swelling, and soft, fluctuant, or spongy tissue suggests pathology. In hard tissue, the necrotic pulp will appear lifeless in that tooth, where crown contour should be noted for fractures, wear facets, and old restoration that will give clue for any kind of pathology. And clinical probing will confirm shift in consistency, because while probing we can feel that there is a break in the consistency of the intact enamel, so that is the location where a dental carie has propagated. It is important to note that Abu Ross recommends that endodontic treatment and crown restoration should be done if a cracked tooth develops symptoms. The reason being that crack can always propagate into a fracture down the line. While performing the visual and tactile inspection, good light at the field of view is very important, and second important is dry conditions. Reason being, for example, there is a sinus opening on top of a tooth. If it is covered with saliva and we do the inspection, the sinus opening will be missed, which is a very important thing to note while we are doing the inspection, so that we know that a tooth adjacent to it is endodontically involved. Also, interproximal caries will go undetected if at the location there is a lot of food particles that is impacted. A significant pocket, if it is found during routine probing, it will mean that it is indicative of a root fracture if in general there is not much of PDL disease that is present. In percussion, it is used to evaluate the status of the surrounding periodontium of a tooth. Mild to moderate blow using the handle of an instrument is used to elicit the response from the patient, or such a blinking of eye. Sensitive response is suggestive of acute apical periodontitis. In palpation, it is done using gloved fingertip. Light pressure is used to be applied, and it is helpful to examine the tissue consistency and the pain response. In mobility, also the depressibility test. It is done using the tip of the handles of two instruments. The tooth is held and laterally it is moved. In case if there is mobility, it is graded as primary mobility first degree, which is slight movement, and second degree, which is about 1 mm in movement. For depressibility, the tooth is compressed vertically into the socket. In that case, the tip of the instrument or a glove fingertip can be used. In third degree mobility, greater than 1 mm of movement is seen and the tooth can also be depressed. Generally, such cases the prognosis is poor to hopeless. Only where in such case also where the acute apical abscess is seen, once the endo process is start and a patent canal and drainage is established, there is a good chance that a good prognosis will be there for the tooth. Bite test. It is used to identify cracked tooth or fractured cusp. Very important for clinicians to notice if the patient says pain on biting, apical periodontitis has to be detected. And if the patient says pain on release of the biting force, it has to be diagnosed to be a cracked tooth. Generally, in the clinical practice, we can use a cotton roll in between the tooth and ask the patient to bite, and then we'll elicit the test. Next, coming on to radiography, it is undoubtedly the most important diagnostic tool. Clinicians have to develop and possess thorough clinical knowledge and skill set necessary to interpret these two-dimensional black and white shadows on the radiographic images. Only then it will help to identify which is a dental carie, the courses, the canals, the calcifications, and numerous more details such as internal and external resorptions, the width of the canal, if there is a taurodontism present, if there are multiple canals present, and so many other more details. It is important to note that Bender and Seltzer concluded in a study that a lesion in a cancellous bone is not discernible on radiographic image until the cortical bone is penetrated. Why this is important is clinically it is usually seen that on a radiographic image when we see any lesion, for example, in a tooth, we see that the dental caries is involving so much of an area and here is the pulp. We might say to the patient that this will go for a filling, but after we actually excavate clinically, we will see that the lesion was actually larger than it appeared on the radiographic image and it went directly for a root canal. So this point is very important. Next, moving on to electric pulp testing. It uses nerve stimulation to determine the vitality of a tooth and it is pretty accurate in nature. The procedure is first we have to describe the entire test to the patient so as to eliminate any kind of fear or anxiety. Second, we definitely have to isolate the tooth. Third, we have to apply an electrolyte. Generally, a toothpaste can be used, which is used on the tip of the electrode, and then it is placed mostly on the occlusal buccal or the incisor labial surfaces of the tooth. And generally, first it is done on a normal tooth. The patient is made to understand what kind of response we are looking for, and then we actually move on to the diseased tooth. Two types of thermal tests are there, the heat test and the cold test. Here, hot burnisher or GP stick is used, and in cold test, the tooth is sprayed with ethyl chloride, which evaporates rapidly, eliciting a response. Now we come on to the anesthetic test. It is used only when all the other tests have failed to identify the causative tooth. Here, infiltration or intraligamentary injection is given for the posterior-most tooth in an area where probably 2 or 3 teeth are being suspected to be the cause of the pain. If the pain persists, we need to inject the tooth mesial to it. So we start with the posterior most, and then if it is the one, we stop there. If it is not the one, we move on to the mesial ones. Test cavity. This is the last resort because it may cause some iatrogenic damage to the tooth. Here, the procedure is drilling is done at slow speed without water coolant. If sensation is felt, the drilling is stopped, sedative cement is placed, and the next tooth is drilled to find out the causative tooth. If no sensation is felt, cavity preparation can be continued and endodontic treatment can be carried out even without any delay. Pulse oximeter. It is a non-invasive technique, still not very commercially used technique. It measures the levels of oxygenated and deoxygenated hemoglobin levels in the tissue that is being diagnosed. And last is the laser Doppler flowmetry. This is also a non-invasive technique. Here, the rate of blood flow is measured. Thus, LDF can potentially be used to differentiate from a healthy traumatized tooth with reduced blood flow from a non-vital tooth where the entire blood flow is absent. That's all for today. We will see you in the next